Hi everyone, welcome back to our latest weekly update from the Goggle Docs team. Umar and I are representing Goggle Docs today, and joining us is a very special guest that we have today, Dr. Sara Ali. Sara is a consultant diabetologist based in my neck of the woods at the Royal Free Hospital in North London. And it's a great pleasure to have Sara with us. Now, Sara is involved in a variety of different areas in the field of diabetes and endocrinology. One particular area where she has an interest is in the management of diabetes in patients from the South Asian community. And that's a particular area that we're going to be focusing on today. But before we get into that, Sara, I was wondering whether you could just share with our audience a little bit about yourself and any specific specialist areas that you want to share with us.
Thank you, Amrit, and thank you, Amar, for inviting me today. It gives me real pleasure and honor to be talking to you. And thank you for the kind introduction. So as Amrit mentioned, I am a consultant diabetologist at Royal Free Hospital. And there I have several clinical lead roles. So one is as the clinical lead for the Barnet Community Diabetes Service, and that's how I know Amrit really well. And I am also the clinical lead for the antenatal service at Royal Free Hospital. I know Amar because of my one of my other hats that I wear, which is as a trustee for the South Asian Health Foundation. And so I've done a lot of work with Amar as well, and we're doing lots of projects in the future. My specialist interests are community diabetes, diabetes in pregnancy. With the South Asian Health Foundation, I have a real interest in South Asian health and trying to reduce health inequalities for South Asians.
So Sara, I know you have a few different roles in terms of guideline development, but also nationally as well.
Yes, that's right. So one of my roles, one of the other hats I wear, is that I sit on the NICE Diabetes Guidelines Committee. And so we're currently updating the diabetes guidelines, which includes the management of type 2 diabetes. And that's a little bit about me.
Brilliant. Thanks for that, Sara. Now, Amar, I know you wanted to bring in our first topic for today, which is management of diabetes in people from the South Asian community. So I'm going to hand things over to you.
No, thanks, Amrit. Yeah, I know it's really interesting. I know it seems like I've known Sara for ages, but it's probably been about a year and a half or so, maybe around that time. And we've not actually physically met, have we? It's all been online or virtually like this, which is, product of the times we're in. But yeah, almost say I know her really well, even though I've never met her. But really, yeah, the focus really today was this article that came out in Diabetic Medicine Journal. I think we can put a link to it right here now. It was a statement, a consensus statement of the South Asian Health Foundation, which I work with as well, and it was really about the pharmacological management of those with type 2 diabetes. Now, I'm sure we're all aware about, firstly, the risks differences between South Asian people and other ethnicities as well. And I guess there is some kind of reason why this has come out, and kind of around this time as well. Sara, kind of what was the reason really for this guidance, or what was the background to this?
So there's several issues. So we know obviously that people with of South Asian origin are more likely to have diabetes, in particular type 2 diabetes. So it's important to have, and the reason for that is various lifestyle and biological reasons. And so I think it's really important, firstly, to have tailored management with all our patients, but in particular thinking about South Asians, it's really important to have a management plan that's individualized to South Asians. And the second thing is the cardiovascular outcome trials that came out, and that really changed the way we look at not only how we treat diabetes, so moving from a glucocentric treatment management just of blood glucose levels, but to thinking about the long-term complications and reducing cardiovascular disease, macrovascular disease. And that's really important when we think about South Asians as well. One thing we know that studies have been showing is that people with of South Asian origin and who have diabetes are more likely to develop microvascular and macrovascular disease. And they usually happen earlier on in the disease. So the fact that those cardiovascular outcome trials, the results came out with specifically for SGLT2 inhibitors and GLP-1 receptor agonists, with the benefit they gave to cardiovascular and renal disease, really helped us think about how we have to change and tailor management of South Asians with diabetes.
I think that's important. I mean, you touched upon an interesting area there with the cardiovascular outcome trials, because as we know, South Asians really are underrepresented across a number of trials, a number of data collections across a number of different studies, and the cardiovascular outcome trials are no exception. And I think in the guidance mentioned that. But I think the whole point of this, as you said, the whole point of the guidance from when I was reading it was really, yes, this is a higher risk group, and so we need to be more intensive and be more aware of it so that we can act sooner, quicker, and more intensively to reduce that risk. And I was interested because I thought it was all Asian males, and myself and Amrit, who are at risk, but in the guidance you mentioned that it's Asian women as well, and different, and it's not just this whole BME, but it's Indian, Bangladeshi, Pakistani. There's a whole lot of variation there. And I think that guideline really does highlight that, and I think that's a really important thing.
Yeah, absolutely. And I think a really important point that you've mentioned is the underrepresentation of South Asians in research, or minority ethnic groups in general, but South Asians, because we're talking about, say, South Asians, really underrepresented in the research trials. And that's something we also talk about, how to overcome the underrepresentation and bring more South Asians into research, particularly with these newer agents, and looking at the outcome benefits so that we can further represent and provide guidelines based on those research results.
So something that I'm really interested in, and I quite often talk about this on our series, is how we bring theory into practice. That's something that I always go on about, because I think that's really the challenge. We've got some brilliant work that's being done academically, obviously. How do we bring that into practice?
Getting these guidelines out will be a real push for helping with educating clinicians about specific tailored management pathways for South Asians. And then I think we need to think about developing educational programs for healthcare professionals that are specifically about South Asian health, which SAF does. I mean, we presented these guidelines at the South Asian Health Foundation annual conference, but we need to really keep going with that momentum. I think it has to go back into the communities as well. So it's about community engagement and improving health awareness.
One of the other areas is obviously in terms of the number of guidelines and the number of recommendations that we have. And obviously this is a very important recommendation, but adds to a handful of different guidance that we have and recommendations that we have. Do you feel there's in the future a role for actually incorporating this kind of ethnicity based sort of risk stratification and management of diabetes within national guidelines, within international guidelines?
That's a really, really good point. I think, we can have so many guidelines, and then it ultimately becomes, which one do you follow? Which one is correct? And they all have different viewpoints. I think one thing that we've tried to do with these guidelines are, whilst it's tailored for South Asians, we are trying to be in keeping with the EASD and ADA guidelines. And then from a NICE point of view, the minority ethnic groups are an integral part, or a big part of our diabetes community. And so we do hope that they will be tailored and all will sing from the same hymn book.
I think that's kind of what I got from when I looked at the guidelines. Is it matches kind of a lot of the other guidelines, essentially metformin, but you've got SGLT2s, GLP-1s, and all those things, and prioritizing it, depending on risk and assessment of risk, which is kind of mirrors everything else. There is a little hint about dual initiation, dual therapy, very hint there, which I think is an interesting consideration in an at-risk group or a more at-risk group, you could argue. So that's kind of there. I'd be interested to see it develop more in the future, let's see. And the other thing really I wanted to mention was what Amrit was saying about bringing it into practice. I think one of the key things really of bringing it into practice is for people at, CCG, local level, whatever level, being aware of their population, being aware of the data for that population. So I work with the community as well in on certain days, and I've asked as part of the searches that we do to incorporate the South Asian or the ethnicity element to that, so we have an idea of what's happening. And that's the very first basic step, is when you're looking at your population, look at the differences as well, not just diabetes or type 2 diabetes, but ethnicity as well. And those are some interesting things to come out.
I understand you're also involved with some work around recommendations for primary care networks and their work in diabetes as well. Is that right?
So I'm working with a group of brilliant individuals in a sort of a multidisciplinary team. So that involves myself as a consultant diabetologist who's very much embedded in community diabetes care, a GP with specialist interest, a practice nurse with diabetes interest, a clinical pharmacist and a dietitian and a community diabetes nurse. Together we worked on an NHS England project thinking about the best delivery of diabetes care in the PCN. And one of the things that we, of course, mention is minority ethnic groups. And it's really important to know your population, not just the minority ethnic groups, but your young adults, your women, etc., and your people who have cardiovascular disease, risk of nephropathy. So it's really, really very important to know your population. And there's a lot of work, really great work going around the country looking at minority ethnic groups and diabetes.
Just listening to what you're saying there, Sarah, it's making me think about the way in which we've made real strides for frailty in the last few years. I mean, we're far from there in terms of acknowledging the impact that the frailty status has in terms of management of someone's diabetes. But hints of similar sorts of risk stratification and identification, hopefully, which will then have a knock-on effect to things such as QOF targets potentially, or QOF points. So yeah, sounds very exciting and interesting, and obviously a really important kind of area to be thinking about, particularly during the pandemic as well, because we know there is such a impact to those people from certain ethnic minorities in terms of COVID complications.
I think the one thing that was in a way good that's come out of the COVID pandemic has really been a highlight of the health inequalities in different groups, so particularly minority ethnic groups. So that's really been highlighted by COVID, but also that diabetes, the fact that diabetes was an independent risk factor for severity of COVID, I think that has really really brought back home the fact that it's important to get good glycemic control and think about cardiovascular risk.
Yeah, absolutely.
One of the things that I would also, just going back to what we were talking about before with, was trying to improve when we're thinking about targeting healthcare professionals, but I think it's also about engaging with the people with diabetes and improving health awareness. So we know that South Asians are more likely to be undiagnosed with diabetes, and it gets picked up later, at which point they have a higher glycemia, higher HbA1c than the white counterparts, but also that they're more likely to have the beginnings of complications. So it's really about getting back into those communities and engaging with them and improving health awareness. And it's taking the service to them, to their homes, to their communities, rather than expecting them to come forward in the first instance, because we know that they don't access healthcare in the same way that other people do. Yeah,
absolutely. So, Sarah, just to kind of wrap things up a little bit, I know we've hardly spent any time on it.
I could talk forever.
I'm sure you could talk forever on it. And it is perhaps something that we'll revisit actually going forwards. If people want to find out more information regarding this, we can put some information into the description below in the video. Are there any particular resources that you'd like to highlight, Sarah?
So I would definitely direct people to the South Asian Health Foundation website. It's got lots of resources. It has our COVID and minority ethnic population report. But then thinking about diabetes, it has a lot of resources there about work that South Asian Health Foundation has done, but also other organizations. And also, if you want to come forward and give us your ideas and we can work together, that would be great as well.
Brilliant. Thanks for that, Sarah. We're going to move on to our second topic of today. And Amar, I'm going to hand things over to you again.
Actually, it's a good thing we have Sarah here, actually, because it's kind of based around this document that's come out from COVID risk assessments, basically, is that we found in the last week or so, there's been an increased number of people put on the risk register because of prior gestational diabetes coding, effectively. And really, that's caused a bit of lack of clarity, perhaps, just on kind of what does that mean and what does that imply when we're talking about, so fine, anyone who's had gestational diabetes is now at a higher risk, implications for shielding, implications for vaccinations and where they stand in that setting, and also just generally about gestational diabetes and that risk. And really, I just wanted to hear your thoughts, really, either of yourselves, on what you thought of that and what that might mean for yourselves.
Yeah, this is an interesting one, isn't it, Amar? So this has been in the medical press over the last week or so. NHS Digital has approved the use of the QCovid risk calculator and algorithm. And as you say, it's included patients who have a history of gestational diabetes. And thousands of them have actually been asked to shield as a result of this. So obviously a lot of GPs and primary care clinicians getting phone calls from patients who actually feel very well in themselves, don't feel as if they are in a risk group, but have had a history of gestational diabetes. And so, yeah, it's causing a bit of an issue in primary care. I suppose one of the things I would say from a primary care perspective is coding and how important coding is. To ensure that that is all kept up to date. But I think there is going to be a pushback on whether gestational diabetes or a history of should actually be included in this risk calculation, not in the first place. Sarah, I'm sure with your kind of experience in antenatal and maternity diabetes, you'll have some thoughts and comments generally about gestational diabetes, but also the link to COVID risk.
So thank you. It's really interesting topic. I think for me, what it highlights is that firstly, if you've got gestational diabetes and it goes away, which it should do in most cases, then, and you go back to the background, HbA1, the normal HbA1c, then why would your risk for COVID be raised? So I think, but what it highlights for me is that a lot of our women who have gestational diabetes, once they've given birth, don't engage with the postnatal check at 6 weeks and then yearly, which is to have your HbA1c checked or look for diabetes. And that's really important because gestational diabetes is an indicator that these women are at risk of having diabetes in the future. So I think it really highlights that we have to be vigilant in primary care and secondary care about how the messaging and getting these women back, and then potentially getting them into a national diabetes prevention program, so that they are less likely to develop diabetes.
I think, yeah, this harkens back to our previous episode. I think we talked a bit about gestational diabetes and cardiovascular risk. And it's interesting, the data that we have that shows risks for people with diabetes and COVID, I wonder how many of them had GDM or a history of GDM. I don't know if we have that data, is the honest answer. And then the other part of me thinks, well, if we're going to have that, then what about those who are at risk of type 2 diabetes, that borderline kind of area we see?
Pre-diabetes.
Yes, exactly, that term that we hear about. Where do they stand on this as well then in that case? And, it holds an other conversation really. And I think that the clarity is the key aspect of this, if it is the risk, and I think that QCovid risk assessment tool is a very important tool. I think anyone has any queries or doubts or unsure about their risk, that tool is what the government are recommending and using. And if you can get on the website and look at that, that's probably the best way of knowing your risk in a way.
Yeah. I think we can also come back to this idea of patient awareness as well. And when a woman has been given the diagnosis of gestational diabetes, what are the implications? What does that mean, not only during the pregnancy, but after the pregnancy and ongoing as well? So I think
absolutely, that's really key.
Yeah.
And I mean, I know I do it, and I'm hoping that all my colleagues do it when they see these women with gestational diabetes. But it's very easy for us to give that information, but then they have a baby and they get overwhelmed with the breastfeeding, the sleepless nights, etc. And it's just reminding them constantly afterwards that they need to go back and have those checks and make changes to their lifestyle to reduce their risk.
Absolutely. So I think the story with risk calculations for COVID-19 risk, the story is to be continued, no doubt. And I'm sure we're going to hear some more things about this particular issue of gestational diabetes in the coming days and weeks. But this is, as with many things during the pandemic, very much an evolving story and process. That brings us to the end of our episode today. It's been really great having you, Sarah.
Thank you.
And it's been excellent to hear about all the work that you're doing in a variety of areas.
I didn't get to talk about my art.
We didn't talk about your art today. Perhaps we can have a separate art episode, and you can talk us through your different pictures and paintings. But brilliant. Thank you so much. Really appreciate it. And thank you to everyone who's tuned in to watch this. All of us from Goggle Docs really appreciate you watching these videos. And if you like what you see, please do subscribe or leave a comment in the comment section below, and we'll be more than happy to interact with you. Finally, if you do want to tweet us, we have got a Goggle Docs Twitter account as well. And I'm just going to put that up on the screen now. Sarah, you also have a Twitter account, which I know you're quite active on. We'll put the details of that up on the screen also.
Right.
So you can get more interaction with everyone from Goggle Docs as well. But brilliant. For now, that's all. Thank you, and we'll see you soon. Take care, everyone. Bye.
Bye.